Welcome back to the podcast of the American Journal of Neuroradiology. Today's topic is the use of an AI program that is commercially available to detect intracranial aneurysms. I'm glad to be joined by the first author of a recent article in the AJNR, Dr. Babatunde Akinpelu, goes by Tunde. He's a clinical assistant professor at the University of Washington, where he is an emergency radiologist. He was a neuroradiology fellow at the time of this research, and the senior author is Mahmoud Mosabasha, who was previously professor at the University of Washington at the time of this project and has recently moved to become the chair of radiology at the University of Alabama, Birmingham. Tunde, welcome to the podcast.
Thank you, Doctor, for having me. Appreciate it.
And before we dive into the details of your research, can you give us a 30-second overview of what exactly you did, what the main question you wanted to answer is?
Incidentally, intracranial aneurysms are detected in about 2 to 5% of patients, which could pose a potential health risk, especially in the setting of subarachnoid hemorrhages. We wanted to see how the detection of these lesions are actually done within the clinical setting for neuroradiologists and how AI actually does with detection of these lesions also. As you know, AI has been increasingly being used in radiology. We've been using it to detect lesions such as brain aneurysms, large vessel occlusions, pulmonary embolisms, mammographic lesions. So we wanted to actually study within our cohort at the University of Washington, how are we doing with detecting these lesions? How does AI compare to fellowship-trained neuroradiologists in detecting these lesions? One thing that we actually theorized was larger aneurysms are going to be easy to pick up for radiologists. But what about those incidental lesions that, you're trying to see, especially ones that are less than 2 millimeter? Can AI detect it better than a neuroradiologist or not? It's a question that we wanted to answer, and that was one of the aims of our research.
Thanks so much for the background. And specifically, the program that we're talking about here is commercially available and produced by a company called AI Doc. And I'm particularly interested in the results of your study because my institution is actually looking into getting an intracranial aneurysm detector, specifically AI Doc. So could you give us an overview of how this program actually works, the kind of images or alerts that it displays, whether they're saved into packs, and do they have a heat map pointing to the abnormality and so forth?
Yes, we can. So the AI Doc actually uses the convolutional neural network within a deep learning algorithm to detect anything that looks like an aneurysm. So essentially, the way it works is like it looks for a vessel that has a focal outpouching. And by looking at that focal outpouching, if it sees that, that focal outpouching doesn't lead anywhere else, it thinks that there may be an aneurysm there. So what it does is like within the background, which I don't understand all the details because it's proprietary, but within the background, it actually looks at where it thinks is an aneurysm, and it assigns like almost like a probability to where you think an aneurysm is. So it now generates a heat map along the slice where it thinks the aneurysm is. As you can see on figure B, the heat map that it generated for us, you can see the hot spot closer to the left PCOM region where it thinks is an aneurysm. So as you can see, the red spot means almost like a probability of 100% that there's an aneurysm, and the blue spot meaning like there's almost 0% as an aneurysm. Once it flags that there's a likely aneurysm, it shows you that slice on a CT and also the heat map. It actually does this in the background. The images are not even opened yet. So as soon as the images are in packs, the algorithm looks at the images without you looking at it. It tells you if there's an aneurysm in there. And also it puts it on our list that it thinks there is a lesion. So in cases of, let's say a patient has an intracranial hemorrhage, AI Doc would actually update our list to say like, oh, there is a potential lesion in this patient. So you want to take a look at it to make sure that, this is really real.
Yeah. And so are these heat maps saved in packs so clinicians can see these heat maps as well?
Heat maps are not essentially saved in packs. I don't know if that's the way we designate it within our institution. I believe it might be site configuration. Don't quote me on that. But you can always go back to prior study and you can look at the case and it'll tell you if there's an aneurysm or not.
So you can run old studies retrospectively through this program as well. And that's what you did for this study, right?
That is correct.
Okay, so let's talk about the design of your study and the kind of cohort that you assembled in evaluation of this program.
Okay, so for our cohort actually was within the UW system. And the PAC system within the UW system actually encompasses like 3 different hospital settings. So we have Harborview Medical Center, which is a comprehensive stroke center, and also our level 1 trauma center. Then we also have two other sites, which are UW Northwest, which is essentially a level 4 trauma center, as well as where lower acuity patients tends to go. And the last center that we did was at University of Washington Montlake. It's essentially a tertiary center or quaternary center where subspecialized patients with thoracic aorta aneurysms or liver cancers, that's where they go to get treatment. So overall, we retrospectively looked at studies within the 3-year span. And the first thing that we wanted to do with our study design is to make sure that all the studies that were done within this time period were finalized by a neuroradiologist to ensure uniformity. The other things that we wanted to make sure was because AI Doc actually flags not just CTAs, but if there is a CT neck soft tissue with contrast, it can detect aneurysms. But we wanted to ensure uniformity, so we removed those from the cohort. So overall, we looked at 2,534 CTAs, and we had a total of 252 positive CTAs with aneurysms. Within this CTAs, we actually had a total of 315 aneurysms. That's essentially tells you that we had about 1.2 aneurysm per detected CTA. And overall, we had 98 aneurysms that were actually ruptured.
Well, to summarize, you took all the CTAs from your 3 hospitals over a certain time period and retrospectively ran the program on these to see if you can detect aneurysms. And you also referred to the radiology reports that were generated by board-certified neuroradiologists to see if there was an aneurysm reported as well. Is that right?
That is correct. One of the most critical things when you're actually designing a research is to have a good benchmark for what the ground truth is. So the way we actually designed what our standard is, we said, if a radiologist called it a positive aneurysm and AI called it a positive aneurysm, we said it's a true positive. If radiology and AI are also concordant that there was no aneurysm, we called it a true negative. The challenge is now anything in the middle. So now if there is discordance between the radiologists and AI in terms of whether there's an aneurysm or not, or if a radiology called it aneurysm or infundibulum, because there are some that we can't really detect specifically what it is. What we did was we had 2 fellowship-trained neuroradiologists looked at this cases that we call discordance independently. Then we actually went ahead and said, if the 2 radiologists agreed, then we use that as either there's a positive aneurysm or a negative aneurysm. If the 2 board-certified neuroradiologists disagreed, we now use the 3rd neuroradiologist to come up with the ground truth or reference standard within the study.
Got it. So you screened the radiology reports, I presume manually, 2,500 reports?
Correct. Initially, we actually used computer programming software like an NLP, a natural language processing, to look at reports to spit out if it's a positive aneurysm or a negative aneurysm. But what we did was, after we did that, we realized that the NLP wasn't 100% accurate the way we wanted it to be. So we did what you were suggesting. We went ahead and looked at all the reports manually to see if there's an aneurysm or not an aneurysm. And that's what we used to compare to what the AI was saying. Yeah, correct.
It makes a lot of sense. I've heard that people want to develop good NLP for these kinds of quality assurance types of efforts, but the NLP is not 100% accurate. It may be 95% accurate, but the thing is you're looking for a condition in which the radiologists are, 98, 99% accurate, and that little 5% classification difference of the NLP could totally ruin your research study, right?
Exactly. That's exactly what we realized in the study. Our NLP was over 95% accuracy, but when you have such a low prevalence rate in aneurysms to begin with, it could definitely throw around your analysis.
All right. So it sounds like a lot of effort on your part, manually reviewing radiology reports and then having neuroradiologists review the images for the discrepancies. Okay. So before we get into the performance metrics, can you tell us a little bit about what your aneurysm cohort actually looked like in terms of, we talked about the prevalence, but, the size distribution and so forth?
Yes. So as expected, most aneurysms that we detected within our cohorts were smaller aneurysms. Smaller meaning that they were less than 3 millimeter. And as you can see, the ones that are greater than 7 millimeter, we didn't have a lot of it in our study. So most of the aneurysms that we had within the cohort were less than 3 millimeter. And for the location, as expected, most aneurysms within our cohort are at the location of the anterior communicating artery and MCA. And as you can see from there, most of the ruptures that we saw within our cohort were at the ACOM and MCA locations. The other third location that we saw a lot of aneurysms were in the region of the clinoid. So around the clinoid segments, supraclinoid segments, PCOM, that's the other location that we saw most of our aneurysms. So those three locations that where you expect to find most aneurysms, and that's what we saw in our cohort also.
That seems really representative of my experience as well in terms of the distribution and prevalence of these aneurysms. So let's get to what the listeners really want to know. So in this retrospective review of a bunch of studies from your institution, how did the AI actually do versus the neuroradiologists?
So compared to neuroradiologists, if you look at the sensitivities, you can see that AI had a sensitivity of 70.5%, while neuroradiologists had a sensitivity of 94%. So we saw radiologists did better than AI, but when it comes to specificity, for AI it was 98.6%, for radiologists 98.3%. In terms of positive predictive value, AI had 87.1%, while radiologists had 88.4%. And when you're looking at the negative predictive value, AI had 96%, and neuroradiologists had 99.2%. In terms of accuracy, AI had 95.1%, and neuroradiology had 97.8%.
It sounds like the AI program was actually set to be not that sensitive, and that was presumably in an effort to be very specific, and it achieved a specificity that rivaled that of neuroradiologists, but its sensitivity was far worse, and overall that meant an accuracy that was just slightly worse than that of neuroradiologists.
That is correct. And one of the reasons why is that the iteration of the AI tool that we utilized was to detect unruptured aneurysms that were greater than 5 millimeter. So at the time of our study, that was the tool that we utilized. With AI Doc, by the time we finished our study, they've actually set their detection rate to less than 3 millimeter, but we couldn't utilize that AI Doc tool for this study. So presumably their sensitivity would improve with the newer iteration of the AI tool.
Well, that's interesting. So you're saying that they advertised their program as detecting aneurysms of a certain size, but nevertheless, it did detect small aneurysms too, right? Like, what did you see is the relationship between aneurysm size and whether AI or neuroradiologists missed it or not?
What we expected, and we looked at a few papers before we actually started our study, like one paper by Sun et al. Showed that radiologists tend to miss aneurysms that are a lot smaller, and which is what we also saw. Like you see from the chart on the screen, radiologists had 89% detection rate for aneurysms less than 3 millimeter in size. But by the time you get it between 3 to 7 millimeter, radiologists were detecting 98% of the aneurysms, which is what we expected. And for aneurysms greater than 7 millimeter, radiologists detected all of them. So as you see, as the aneurysm size got bigger, the radiologists had better detection rate or sensitivities. The reasons for this is the chance you won't perceive it becomes less as the aneurysm gets bigger. Not only that, within our cohort, the larger size aneurysm tend to present with rupture, which increases sensitivity for the detecting aneurysm because your index of suspicion is now really high because there is blood and you have to find an aneurysm or a lesion. On the other hand, with AI Doc, the iteration of tool that we use wasn't designed to detect aneurysms less than 3 millimeter, but AI did detect about 73% of aneurysms that were this size within our cohort. But what we also noted was by the time we went to 3 to 7 millimeter aneurysm, their detection rate was 70%. And by the time we got to aneurysms greater than 7 millimeter, their detection rate was 64%, which is almost like an inverse trend compared to radiology. One of the things that I could actually explain this is the larger aneurysms within our cohort, a lot of them were ruptured. So the AI Doc tool was not designed to look for ruptured aneurysms. So we'd expect them to fail a little bit more with the larger aneurysms that were ruptured.
So it's very interesting seeing where AI fails because, as you mentioned, there's kind of a counterintuitive inverse relationship of the performance of the AI compared to the performance of radiologists. The larger ruptured aneurysms were missed more often by AI than you would expect compared to the smaller aneurysms, which it detected, even though it was not labeled for the detection of those very small aneurysms. Could you go over with us some examples of the reasons that AI got it wrong, either false positives or false negatives in your cohort?
Yeah, so some of the false positives that we had in our cohort was that a lot of times when you had a small vessel that did a hairpin turn, sometimes the hairpin turn can actually look like a focal lesion, especially the smaller the hairpin turn. So overall, within our cohort for AI, we had 8 false positives that were basically vessel turned. And that's essentially 24% of the failure mode that we actually had within the cohort. In 6 cases, there were like bright calcifications within the vessel that looked like a focal outpatching, and AI thought that that was an aneurysm. In another 6 cases, it was apparently an infundibulum.
I just want to throw up the figure that you had in your paper that illustrates some of these false positives. So there was an example of tortuosity of the distal basilar artery that AI interpreted as an aneurysm, but upon reformats, that was just a normal vessel that was a little bit tortuous. And then calcification, we see carotid siphon calcifications a lot, and it seemed like AI misinterpreted one of these calcifications as an aneurysm. I have also seen radiologists misinterpret this because the density of calcification could be similar to that of a pool of contrast. And then finally, there was one example he gave of a venous varix that was downstream of a arteriovenous malformation that was misinterpreted as a arterial aneurysm.
And I'll add, the venous varix and AVM, that one is quite challenging because a lot of times you don't know if it's a venous varix or actually intranidal AVM aneurysm. So that was challenging for neuroradiologists also. So you see how AI can also label it a false positive.
Got it. So we'll give it a pass. So how about the false negatives now?
So false negatives, a lot of the false negatives that we actually saw within our cohort were where the tool was not designed to be able to detect. One of them is when it's ruptured. So in 44 aneurysm cases, there were aneurysms that were actually ruptured. And for example, on the left of the images, you can see a ruptured myocardic aneurysm, and the contrast around it may be making the aneurysm less visible to AI to detect. On the middle image, you can actually see another false negative. You can actually see a case where the patient was actually actively bleeding at the time. And you can see the bright blood or contrast around the aneurysm could actually prevent AI from detecting it. And the patient actually had false negative from this AI tool. When patient was transferred over to Harborview Medical Center, the CT scan was repeated. And as you can see on the right side, the AI doc tool actually picked it up this time because, there was not a lot of bright contrast around it. And you can see the focal outpouching of the right MCA really clearly. So you can see in the case where the AI doc actually missed it initially based on the fact that the patient was actively bleeding. And when the active extravasation was done, AI then picked up the aneurysms as a true positive. So,
got it. So it seems like the presence of hyperdense blood in the subarachnoid space around aneurysms was a frequent failure mode for the AI because it had trouble detecting the aneurysm when it is not being surrounded by clear CSF. Is that right?
That is correct.
Great. So these are some really great teaching cases just to show people examples of how not to get tricked, how not to be confused if given AI output for intracranial aneurysm detection. Can you give us some of the other way around? Are there examples where AI actually added value beyond the neuroradiologist, instances where it found aneurysms that the radiologist did not?
That is absolutely correct. Like we mentioned, within the study, we had a total of 315 aneurysms. And if we just utilized neuroradiologists alone, we did not detect all 315 aneurysms. So by retrospectively looking at the CTA, we found a total of 19 aneurysms that radiologists didn't detect initially. So one could theorize that if you had utilized both AI and neuroradiologists from the get-go, we would have captured this 19 aneurysms. So we do theorize that, there's incremental value in utilizing both AI and neuroradiologists for better patient care or increased sensitivity in detecting all the aneurysms within the cohort.
Let's hit some limitations before we close. So as you mentioned, you're theorizing that, AI could have picked up 19 aneurysms as a radiologist. However, your study is a retrospective review. This was not a prospective review of the implementation of AI doc in your practice. When actually implemented, radiologists could behave differently, detect either more sensitively or less sensitively with the aid of AI. Any other limitations to your study that listeners should know about?
One of the main limitations is finding the true ground truth within the study. It's always challenging to know how many aneurysms were actually within the cohort. The way to design the study was if a neuroradiologist called it positive, that's an aneurysm, and AI also said positive that there is an aneurysm. That was the total number of aneurysms within the cohort. But in reality, there could be 1 or 2 aneurysms that we missed within the cohort that we did not actually account for which could potentially skew the analysis overall. So that was one of the first limitations we had in the study. The other limitation is like this study was within a single institution, within 3 different healthcare systems. When you expand this to other institutions, other regions where they have different prevalences, the results could be a little bit different. Some of the other limitations was we use one specific AI tool. When you start to use different AI tool, you can have a different result. So those are some of the challenges that we had within the study.
Now let's bring this home. What are some take-home messages for neuroradiologists and fellows who are reading CTAs tomorrow on call if they have this AI tool already implemented at their institution, or for groups like mine who are considering buying this tool?
Moving forward, there's going to be an ever-increasing need to utilize AI with neuroradiologists. And that's for better patient care. The tool that we utilize, specifically AI Doc, my experience is I found that it's actually quite helpful because, like I said, it helps flag if there is a potentially positive case. It can move it up in your queue. So if there is a potential lesion, it can make you see it. In the setting of incidental aneurysms, where sometimes you're not really looking for it because patient came in with a headache, it can flag aneurysms that are less than 2 millimeters, which was the ones that are more likely to be missed by radiologists. But one thing that you have to understand when you're utilizing AI, you have to also understand there are limitations to it. You have to understand that there are some false positives and some false negatives. You have to know where the failure modes are, and you have to know how to debug them to make sure that you're actually telling the referring clinicians exactly what you think it is. Because at the end of the day, a radiologist is going to be the one that's responsible for all the images. So it's important to make sure that you know where the failure modes are and know how to interpret AI in terms of its detection rate and its true value.
In my view, it seems like AI could be a helpful second reader. It's far from perfect and it performs worse than neuroradiologists, but for high stakes pathologies such as aneurysms that could rupture down the line, it may be appreciated having a second reader, even if it's far from perfect in sensitivity in flagging potential cases of aneurysms that we might have gone by in our first search.
That is correct. And as you know, time with increased database, AI is only going to get better. And as it gets better, its value is actually going to increase over time.
And as we adapt to additional iterations, it behooves us to be aware of the failure modes of AI so we don't get confused. If it flags something and we don't know how to debug it, well, now we know it could be tortuosity, it could be a calcification, it could be a venous varix, and so forth. And so we just have to keep that in mind about ways that AI can be confused in ways that radiologists may not.
That is correct. You summed it up perfectly.
Thank you so much, Tunde. Dr. Akinpelu is the first author of this recent AJNR article. Readers can find it on the AJNR website. Thanks so much for listening. We'll see you next time.
Thank you so much. Appreciate it.